Maybe I was a fool to hang on to someone that would never change.
Anticonvulsants. We're going to start with some terminology. So idiopathic epilepsy is epilepsy of unknown cause, and of course epilepsy itself. We're talking about a disease process or just the general process of seizuring, having seizures. So epilepsy tends to be given as a diagnosis to an animal when they show regular seizures, because of unknown or genetic origin, i.e. it's not because the animal got into a toxin and had a seizure and that was it. Status epilepticus is the act of having a seizure. And to clarify, seizures are periods of altered brain function characterized by loss of consciousness, increased muscle tone or movement, altered sensations, and other neurological changes. Convulsions are seizures that manifest themselves as spastic muscle movements caused by stimulation of motor nerves in the brain or spinal cord. Some seizures can result in no apparent convulsive activity, but may appear more like the animal is in a state of semi-consciousness. So we'll talk about that one in a little second here. Let's see here. So then preictal phase is an indication that the seizure is about to happen. And during this phase, it's also called the prodromal phase, but the animal typically will seek out their owner. They might become a little bit more needy. And then ictus is the seizure itself. So the ictal phase or ictus is the actual seizure. And then we have generalized seizure is a term given to a seizure affecting the entire brain and body. Focal seizure, I'll show you a video of in a second. It's a partial seizure, and it's a seizure that just affects a part of the brain. So there might be neurons firing like crazy in one specific area of the brain, so that only is affecting a part of the animal. The whole animal isn't a full-blown seizure. Post-ictal phase is the time after the seizure has occurred, and I'll show you that as well. A little bit more genetic epilepsy are seizures traced to a specific breed or line of breeds. Structural epilepsy is the cause is traced to specific lesions in the brain. So that could be a tumor or an injury. Unknown origin is, of course, the cause being unidentified. So this is a video of a partial or focal seizure. So the dog is conscious and he's just hanging out, his tail's wagging, you can tell he's a little bit nervous, and his head is tremoring. Okay, so that's a focal seizure. And then this is the post-ictal phase. The post-ictal phase, you can see the dog is really quite out of it, and then he or she becomes a little bit more aware after the seizure effects are dissipating. So at first, he or she isn't making any eye contact, just kind of thrashing head around, trying to figure out where the heck they are, what happened, and then now they're a little bit more responsive, focusing on the owner when the owner calls the name. Really important, during the post-ictal phase, we always want to tell the owners, during a seizure, keep your pet safe. During the post-ictal phase, keep them safe, but don't be hands-on. Okay, so put them into a position, get them into an area where they're safe, where there's padded substances around, but don't try to hug or control the animal right after seizures or during the seizures. Because as soon as they enter into this post-fictal stage, there's potential that they're not aware, and they're just really scared because they woke up because they have no idea what just happened to them. And then, of course, somebody's trying to hold them and they can bite. So just to be very, very, very aware of that. During the ictal phase, so the true seizure itself, if it's a generalized seizure, expect to see the dog or cat on its side in lateral recumbency, thrashing, normally with their head thrashing, and they're paddling. So their paws are looking like they're swimming, but they're going nowhere. Okay, those are typical questions that we ask the owner. If they call to say that their animal just had a seizure, quite often I'll ask, can you describe it for me? And sometimes it might not be a seizure, it might be something like vestibular syndrome, which looks different. And then, of course, how often are they having them? How long are they lasting? That kind of thing. So epilepsy versus other seizures of epilepsy most of them are not life-threatening. Seizures of unknown origin or toxicity or an injury or a lesion on the brain, of course, too. These are more challenging to maintain and to manage, and they're more likely to cause long-term effects or worse. Risks of seizures, of course. So when an animal has a seizure, we have to remember that their muscles are moving like crazy, crazy, crazy. So they tend to get very hyperthermic. So their temperature increases because muscles produce heat when they're contracting. They can also get hypoxic because their thoracic cavity can't expand to bring in the air that they need to keep going because their muscles are all tight. And they might undergo severe acidosis as well. And that, of course, is because their muscles are going. They release so much lactic acid in their muscles because they're just constantly contracting. So they can result in an overall severe acidosis. Suspected epilepsy. So if the doctor suspects that the animal does in fact have epilepsy, then they should be discussing the risks and benefits of daily anticonvulsants. Most often, it's discussed based on how often they're having seizures. Sometimes animals only have 1 seizure or 2 seizures a year. It's not worth the risks of putting them on a daily anticonvulsants if that's the case. It's when they start increasing in frequency that we start to identify that there's a change, and that may be the reason that they need to go on daily medication. Equine or cows, like large animals in general, if they have epilepsy, unfortunately, that's pretty much a guarantee for euthanasia because the risk of them having a seizure when a human is around them or on them, if it's a horse, that's life-threatening for people. So the risk of safety with these guys is just too great, and it's too much. It can be too impactful on human life. Likewise, too, they're so large that when they have seizures, we would never want a horse to fall and get its leg caught, break its leg, anything like that that would, create long-term agonizing pain. So quite often it ends up in euthanasia. When we're talking about medication for anticonvulsants, for epilepsy in general, we're always talking about control. So we're never looking for a cure specifically at this point, or we're never expecting a cure. We're expecting an ability to control the seizures, and we're controlling the frequency of the seizure. So looking at our medication, phenobarbital, you'll find familiar because we talked about it when we talked about our general anesthetics. It is a barbiturate, which is a drug, in this case, it's a drug of choice for long-term oral dosing as a control of epileptic seizures. It decreases the likelihood of spontaneous brain cell depolarization, so it prevents the likelihood of those crazy firing neurons throughout the brain, and it slows the spread of depolarization across the brain. Because depolarization, of course, happens in a wave, and when one cell depolarizes, then, of course, if it's connected to another cell, the synapses just continue and continue. This increases the effect of GABA, so phenobarbital increases the effect of GABA, which then allows chloride ions into the cell, into the neuron, which creates a negative atmosphere in the neuron, which of course decreases the chances of depolarization. Phenobarb has a long half-life and it's given 1 to 2 times daily depending on the needs. As with every good drug, we have to, of course, review its negative side effects, and there are just a few with phenobarbital. So we've got polyphagia, PUPD, increased metabolism of other drugs. So this is kind of interesting. They also develop a tolerance to phenobarbital itself. So when they're on phenobarbital, they create enzymes. They have this induction of enzymatic activity in their gut. So these enzymes typically live in the liver. They naturally biotransform phenobarbital. Unfortunately, their presence is also increased and induced by phenobarbital. So we know that these enzymes, A, they break down or they biotransform phenobarbital, which makes it less bioavailable to the body. And then B, the more phenobarbital we give, the more likely these enzymes are to occur. Okay, so they come out with phenobarbital. It's really weird. So the more you give phenobarbital, the more efficiently the body metabolizes it. This is also the case with a lot of other drugs. So you have to be cautious when we're giving phenobarbital. It might cause increased metabolism of other drugs as well. It has wide individual variance of the dose, so some individuals tolerate it really well, some do not. It can cause initial sedation in the patient, and it's important to let the clients know that this should go away in the first 2 to 3 weeks of treatment. So we have to let them know it can last up to 3 weeks. It can be hepatotoxic. So typically ALT and ALP increase initially and then normalize during treatment. And sadly, it can cause severe ataxia if an overdose occurs. So that's something to be aware of when we're talking about the sedation for the pets. We have to let the clients know that we're not talking about severe ataxia, because if that shows up, then of course potentially they've been overdosed. Adjusting the dose may cause breakthrough seizures, and we have to have caution with hypoproteinemia. So phenobarbital is highly protein bound. Therefore, animals without normal levels of protein allow free phenobarbital to enter the brain at a faster rate. The use of certain drugs such as aspirin or sulfonamide antimicrobials also increases the amount of free phenobarbital by displacing the barbiturate from its sites on plasma proteins. So if an animal already has reduced plasma protein levels, we have to be cautious using phenobarbital. Some animals, of course, also get hyperactivity on phenobarbital, which is always a little bit scary and generally means that they can't have phenobarbital, that we have to switch them out for a different medication. So, of course, with all of this, it is a bit of a yikes, and of course, we have to be careful. Now, phenobarb also, it's often measured in grains, so 1 grain is 60 milligrams, and tablets are usually available in quarter, half, 1 and 2 grain sizes, roughly corresponding to 15, 30, 60, and 120 milligram sizes respectively. Here's our handy dandy chart. Class, barbiturate, trade name, phenobarbital. Quite often it's called phenobarbital, but you might see it as phenoleptyl or luminol. Luminol definitely is the human form. Mode of action, it binds to GABA A receptors and blocks AMPA receptors. It also increases that effect on GABA itself. It's the #1 choice for long-term seizure control. Has a long half-life, which means less frequency of dosing and a lot more client compliance. The downside, of course, is polyphagia, polyuria, increased metabolism of itself and other drugs. They develop that tolerance, wide individual variance of effect, initial sedation, hepatotoxic. The adjusting of the dose may cause breakthrough seizures, and caution with hypoproteinemia. Could cause hyperactivity, and of course client compliance. When we are going through the initial dosing phase, the clients have to be compliant in bringing in their pet for serum or plasma level testing, so to ensure that the right amount of phenobarbital is circulating in the plasma itself. Also, at least once a year we should be checking their liver values as well. So the routes are IV and oral. If it's IV, it's a really, really large volume, typically, because it's a low concentration. So then we have this one, zonisamide. I don't have too much about zonisamide. It's also known as Zonegran. It's an anticonvulsant medication that's used by veterinarians to treat dogs and cats that are suffering from epilepsy. It affects the sodium-potassium channels in the neurons in the brains. So essentially that is inhibiting the likelihood of depolarization. This is typically one that's given to animals who are on phenobarbital, and it might be added as a complementary medication. Or if the animal can't have phenobarbital, then we might try zonisamide as well. Biggest challenge with zonisamide is it's very expensive. It's impossibly expensive. So it's really challenging for the client. That's all I really have to say about that one. Diazepam. So this is a benzodiazepine, as we already know. It enhances the inhibitory effects of GABA. It has very short duration of action due to that first pass effect. Best for immediate use in status epilepticus patients. And long-term seizure control, we have to switch drugs. Okay, it can become very, very bad for the animal over time. We can give it IV, rectally, and transmucosally, and sometimes we can offer it as a CRI, but I'll talk about the challenges with that in a second. So just a reminder, going back, the first pass effect, the drugs are rerouted to the liver when initially given. When they enter the liver, they're rapidly metabolized before they actually reach the blood circulation. So that happens with a few of the drugs that we've talked about. And then in this case too, when we're talking about CRIs, it is possible to be given as a CRI, but the challenge is, we've already discussed that diazepam does not mix very well with water and with most solutions, because most solutions are water-based. So if we're giving it as a CRI, we have to be sure to add it to our bag or our Buretrol and then invert the bag very, 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 very well. Some people as well will actually flush the IV line with Valium, so with diazepam, to coat the IV line and then run the mixed solution through. I don't know how successful it is. To me, it just sounds like a lot of wasted narcotic or wasted controlled drug. We also have to remember that Valium changes in plastic and it can cause precipitates and it can stick inside the IV tubing altogether, just create those little precipitate chunks. So it's not really ideal to be given as a CRI. I think at that point, then of course the doctor has to find out why that animal is seizing uncontrollably and look at their realistic options from there. So diazepam, has less ability to be metabolized by cats, and of course, as we talked about previously, there's potential for long-term liver failure as well. The effects of diazepam on behavior, generally they're pretty sedate, relaxed, their muscles are relaxed. We could potentially unmask unwanted learned behaviors, so bite potential, because we're reducing their inhibitions, right? We're making them feel really, really good, which might make you think that we reduce the chances that they'll bite, but sadly, if they have some of that learned behavior, like if they are really food aggressive, but it's pretty well managed at home, if they're on Valium, they might just be really food aggressive because they're feeling really good. As I say that, my aggressive dog starts growling in the background. Silly Cinder. Okay, diazepam. So class, it's a benzodiazepine. The trade name is Valium. It can be given deep IM, rectal, IV, or intranasally, and we often give it IV. We often send it home with owners to be given intrarectally. Mode of action, attachment to GABA receptors, and it enhances the effect of GABA. It's the number one choice for status epilepticus, so actual seizing patients. Causes nice muscle relaxation, seizure inhibition, and it's safe for cardiac and respiratory patients, which is really great when we just have a seizing animal be rushed through the door with no known history. Side effects, very short acting. First pass, so it gets metabolized by the liver first and then into blood circulation. Cats are less able to metabolize and it becomes quite hepatotoxic over time. Caution with reduced inhibition for biting. And it doesn't mix well with water and solutions, which makes it challenging, of course, for CRI usage. So then we have bromides. These are chemical reagents. So we have various types of bromides. It could be potassium bromides, it could be sodium bromide. And they're not actually a drug, but they are a chemical reagent. So essentially like a chemical carrier. How does it work? Likely, it increases the likelihood of chloride entering into the cell to decrease the chances of depolarization, but they're not entirely sure how it works, not 100%. It does have a really long half-life of 21 to 24 days, but, so that's a long time, right? That can mean that we're not seeing the effects that we need to see until at least 24 days. And quite honestly, it often takes 3 to 5 months to reach a steady state concentration in the blood. That's a really long time. So what we do in that time between, because it can take so long to reach a steady state in the serum or in the plasma, then we can give a loading dose. So we give a higher dose to start with that can help sort of bolus and push that threshold forward and push that serum level higher immediately, and then it will just carry on with normal doses. So it's kind of interesting. Potassium bromide, generally it works overall as a method for decreasing that spontaneous discharge of those neurons in the brain. So potassium bromide is the one that we use most common in clinics. We typically get it compounded in a big jug and then dispense it to our canine patients. We do not give it to cats. It is not metabolized well. It's toxic for kitties. Potassium bromide overall and bromides in general, they're not the first choice. They're generally for animals who can't have phenobarbital. So if they are reactive to phenobarbital, they become hyperactive instead of sedate, or in combination with phenobarbital. So if we're already on phenobarbital and they're still having breakthrough seizures, then they might add in a potassium bromide. That's most often when I've seen it used is in combination with phenobarbital to help reduce the chances of those breakthrough seizures. Interesting thing about potassium bromide is that the effective dose is very close to the toxic dose. It has a narrow therapeutic index, so very, very narrow therapeutic index. Therefore, if a loading dose, so that initial bolus, if we overshoot the therapeutic range, it can produce toxicity. So when we're starting patients off on potassium bromide or bromides in general, and we're starting them off at a loading dose, we really have to warn the clients about the potential toxic effects. So we're going to have them watch out for anorexia, vomiting, diarrhea, sedation, stupor, or coma. And the long half-life means that the side effects are actually going to be present for hours to days. So it's really scary stuff. We have to be very aware of it. A lot of this all comes down to client compliance, right? So we have to tell them what to expect so that they feel a little bit more comfortable talking to us about negative and positive side effects. Another downside. With bromides in general, vomiting may occur even if the dose of potassium bromide is within an acceptable range. So this appears to be a direct effect of the salt on the stomach, so the salt contained within the medication, which produces gastric irritation. Vomiting can be reduced by using a liquid formulation instead of a capsule, and by dividing the prescribed dose into twice daily or 3 times daily doses, and by trying different foods to be given with the potassium bromide to see which ones are tolerated the best. So again, if we warn the clients that vomiting might occur sort of immediately after giving the potassium bromide, if we warn them about that, then they're not going to be as scared when it happens. And then they'll be more likely to tell us so that we can work with them to figure out what would work best to reduce the chances of vomiting. Have we switched to a liquid? Have we given a certain type of food? Have we broken down the dosaging, etc.? So it's all about compliance with us in anti-seizure medications because, of course, if the medications are not being given according to protocol, then we could either create toxic effects, which are very, very scary, or, of course, that animal is going to come right back to seizures quite soon or have breakthrough seizures. So for us, our VT role is to discuss the clinical signs. Really important. Discuss the clinical signs. Encourage regular blood testing, so plasma levels, serum levels, organ function. Discuss potential for breakthrough seizures. And of course, discuss the side effects of potassium bromide as well as other medications too. So here's our little chart. For potassium bromide, we give it orally. It's an anticonvulsant. You might see it called K-Bro, which cracks me up. So K-Bro Vet, it just makes me think it was made in like California for surfers on the beach or something. But normally it's just potassium bromide, typically compounded. The mode of action, they're not entirely sure. It's likely to act the same as chloride ions, so essentially reducing or act on the chloride ions to reduce the chances of that cell depolarizing, meaning that chloride ions are negative and they are allowed to come into the cell at higher rates to keep it nice and negative inside. Positive effects, it can be used in combination with phenobarbital. It's less frequently given as well. That's kind of positive. Downsides is, of course, it can take weeks or months to find the ideal dose. It's for dogs only, and sedation and ataxia can happen, so we have to warn the clients about that. Close monitoring of blood levels, and of course, the vomiting. Unfortunate. And that is it.